Our next speaker is Dr. Eric Campion. He's a member of the GEITS division and is based at Denver Health. By way of background, he did his schooling, I guess, in Michigan. His undergraduate degree was at Eastern Michigan University, and then went to the University of Michigan in Ann Arbor for medical school. He did his general surgery residency at the University of Cincinnati, and then did a tax fellowship at UCSF and San Francisco General Hospital. He started on faculty here in Colorado in 2015. He's the Director of Surgical Patient Safety, Associate Director of Service for Surgical Services at Denver Health. He's well-published, 45 peer-reviewed publications. He's an excellent clinician and sought-after teacher, and runs a very busy service at Denver Health. His talk this morning is End-Tidal CO2 predicts massive transfusion and death. We look forward to your talk. Thank you.
Okay. All right. Thank you. All right, well, thank you very much. I really appreciate the opportunity to speak to you all today, and I really appreciate our long history of academic collaboration between our two institutions. So I'm going to talk today about interest that's particular to mine, looking at end-tidal carbon dioxide and its ability to predict both traumatic injury and death. I don't have anything to disclose. So carbon dioxide is, I think most people in the room are well aware of, is a byproduct of aerobic cellular metabolism. It's transported in the venous circulation to the right heart and then diffuses across the pulmonary capillaries and enters expired air. End-tidal carbon dioxide is the level of carbon dioxide in that expired air as measured by capnography. During normal physiology, the end-tidal carbon dioxide is essentially equivalent to the plasma carbon dioxide as measured on ABG, within 2 to 5 millimeters of mercury. However, during abnormal physiology, significantly decreased cardiac output, deranged ventilation or VQ mismatch, these can become discordant. And we'll talk a little bit more about the low cardiac output state because that really relates to the hemorrhagic shock of trauma. So decreased cardiac output results in low pulmonary circulation, which can lead to decreased end-tidal CO2 as compared to what you see in that arterial circulation. So what we were discovering at Denver Health is that we had a trend of patients that were undergoing big trauma operations that were significantly hypercapnic once they got some ABGs drawn in the operating room. And we posited that this may be to a potential over-reliance on the end-tidal CO2 to guide ventilatory management. Now, the fact that the end-tidal CO2 can be discordant has been known for a long time. What we were noticing is that the simple fact that the number on the screen looked good was giving kind of an over-reliance and over-comfort to folks up at the head of the bed. So we decided to study this a little bit more rigorously. So we performed a multi-center trial through the Western Trauma Association, looking at all adult patients that had an exploratory laparotomy in 2017. We looked at the end-tidal CO2 and ABG values within the first hour of that operation and looked between those values at a maximum time interval of 5 minutes. You can see there's 13 centers involved, including Denver Health and the University of Colorado. We hypothesized the end-tidal CO2 was not representative of the plasma CO2. When you look at our patient population, you see we had 256 patients, and typical to a trauma study, we have a young male population. You can see here a very high penetrating trauma rate at 54%, severe injury with an ISS median of 22, and a very high mortality rate at 21%. So when we looked at that first ABG in the operating room, we noted that almost 60% were acidotic, 45% were hypercarbic, and 40% were both. And so 40% of patients were acidotic, but still had a CO2 that was well above 45, and certainly not an ideal state for patients that were trying to manage their acid-base status. We then looked at the correlation between the end-tidal CO2 and the plasma CO2 in this population, And with an R-squared value of 0.04, it's essentially a scatter plot. And so there really was very poor correlation between these two values. And we noted the correlation was significantly worse in patients who were acidotic and hypercarbic. We then looked at the correlation between these factors and found that 45% of the patients had a greater than 10 millimeter mercury disagreement. So that's a very clinically significant disagreement between those two values. And 15% had even larger, a 20 millimeter mercury disagreement. 94% of the patients that did have a disagreement had the end-tidal CO2 values lower than the plasma CO2, which gets close to 100% when you have significant disagreement. So the end-tidal CO2 is underestimating that plasma CO2 in this population. We looked at the predictors of the poor correlation and identified the age, ISS, pH, the needing blood transfusion, and AIS chest, so chest injury, were all predictors of poor correlation. We did a regression analysis and identified that acidosis was the most significant factor, followed by age with a very small relative risk there. When we got to 20 millimeters of mercury disagreement, same factors apply with a much higher relative risk to those. So we looked at this as a univariate analysis initially and identified that if you have a 10 millimeter mercury disagreement between your plasma CO2 and your end-tidal CO2, your mortality goes from about 5.8% to 38%. And when we get to the 20 millimeters of mercury disagreement, is from 11 to 66%. So we have identified that this is a marker, a significant risk of mortality. We then performed a multivariate analysis, controlling for those factors that we already spoke of, and identified that there's relative risk of 3.7 for a 10 millimeter mercury disagreement and 2.6, so about the same when statistically, but this is a marker of significant risk of mortality. Now, of course, in this study, it's a retrospective study. There's definitely a potential survival bias. Unmeasured confounding is always a risk. And then there's a risk of documentation errors on any of these retrospective studies. Lastly, the time interval between the AVG and end-tidal CO2 measurements, we selected a maximum of 5 minutes between those. But of course, if there were significant ventilatory changes or other factors, it's possible that the time interval we chose was still a little bit too big. So the conclusion from this study is that patients were during emergent operation are frequently acidotic and hypercarbic. End-tidal CO2 is very poor correlation to plasma CO2 in this specific emergent trauma population. A large number of patients have a greater than 10 millimeter of mercury disagreement. And it's important not to base your ventilation on your end-tidal CO2 in patients in shock. So then we started to think, okay, we were able to demonstrate that end-tidal CO2 is a marker of both mortality and potentially blood loss in a emergent trauma population. Well, that's great. And I think it's important that we recognize we want to affect our ventilatory management, but we also said, hey, can we use this to help us predict in the pre-hospital arena which patients are at risk? So pre-hospital trauma triage has really been unchanged for decades. Physiology has been measured by classic vital signs such as blood pressure, heart rate. If you want to get really fancy, you can do a little math and create a shock index. The ACS minimum trauma activation criteria, which you can see here, really uses those basic vital signs and a few other select factors on injury to determine which patients are activated. However, this does not at all reflect any sort of advanced measure of physiology and leaves a lot to be desired. With the new miniaturization of technology, including point-of-care labs, and new physiologic measurements that are now available, along with end-tidal carbon dioxide, I think we can do better. So any pre-hospital trauma triage tool, you'd like to be rapid, like to be cheap, easy, continuous ideally, so you can make changes based on the measurement, and you want it to be predictive of shock or outcomes. And I'd like to propose that end-tidal CO2 has a potential to be all of these. So end-tidal CO2 is already being used on ambulances across the country. It's essentially become the standard of care for determining whether or not endotracheal tube is placed in the correct position. There's a number of studies that have looked at end-tidal CO2 levels in cardiac arrest and looking at CPR quality, which really reflects on that same kind of cardiac output principle. So lastly, is it possible that we can identify shock using end-tidal CO2 as one of the factors? End-tidal CO2 monitoring is already miniaturized. It's built into a number of other devices, including almost all pre-hospital monitors. It's widely available, it's real-time, and it's continuous. We began by performing a retrospective single-center study at Denver Health. We looked at all adult trauma patients that were intubated prior to arrival in the emergency department, and we evaluated the predictive performance of end-tidal carbon dioxide compared to systolic blood pressure and shock index. We used the Uden index to determine optimal cutoffs, and we looked at massive transfusion. So here we have 173 patients, again, a young male population with high penetrating trauma rate, pre-hospital CPR at 29%, so a significant portion that were undergoing CPR in the pre-hospital arena, severely injured with a high mortality rate. And here you see that end-tidal CO2 in this population was definitely predictive, and just as predictive as blood pressure, if not a little bit better, both looking at the highest end-tidal and the lowest end-tidal en route. We then looked at its ability to predict for massive transfusion and identified that there was a significant predictor of massive transfusion with a cutoff around 22 millimeters of mercury in this study, and a very high positive predictive value and relatively high negative predictive value, and really comparable to blood pressure in this small study. So this small single center study is helpful to be a proof of concept, but we wanted to expand this out to a much larger study. And so this is a large multi-center trial through the Eastern Association of Surgery of Trauma. It's a retrospective multi-center review of all adult trauma patients intubated prior to arrival during 2017 and 18. We again looked at end-tidal CO2 compared to blood pressure and shock index with the Uden index as well. So here you see there's a number of organizations, including Denver Health and CU. We identified 1,300 patients in this particular study. Again, young male, severely injured, high penetrating trauma rate, and high mortality. We looked at the predicting of mortality. You see that end-tidal CO2 was a significant predictor of mortality and better predictor than both shock index and blood pressure. We then looked at massive transfusion, identified that end-tidal CO2 was a significant predictor, but did not prove to be better than shock index or blood pressure in the overall population. So then we went to say, well, if a patient's already hypotensive, they're already going to be triaged to the level of severe injury. They're going to be in activation. So let's look at the patients that are in that normotensive subgroup. And here we identified that end-tidal CO2 significantly outperformed both the shock index and blood pressure with a relatively high negative predictive value. Sorry, wrong direction. Again, looking at massive transfusion, we identified that the end-tidal CO2, again, was very predictive of massive transfusion in this population, and better than systolic blood pressure and shock index, although not statistically significantly. You can see the p-value there of 0.1. So in conclusion, pre-hospital end-tidal CO2 is predictive of mortality and massive transfusion, and it may be more predictive than systolic blood pressure and shock index, especially in patients without hypotension. So what are limitations here? Well, we only looked at intubated patients in both of these studies. And so there's, like any retrospective study, there's unmeasured confounders and other factors. So where do we want to take this in the future? Well, we're actually just concluded a prospective observational study looking end-tidal CO2 via nasal cannula. So that's really the next step in this research, in that, you know, once patients are intubated, we're already kind of triaging them to the significantly injured cohort. And so we have just completed the study and are doing the data analysis at the moment. We hope to be presenting at Southwestern Surgical. We'll be submitting an abstract for that meeting. And then I'd like to follow it up with a much larger prospective multi-center trial looking at end-tidal CO2 via nasal cannula and trauma triage. So I'd like to thank some of my mentors, including Clay Cawthorn-Burlew and Mitch Cohen, who are mentoring me with these studies. I'd like to thank Dr. McIntyre and Robbie Dumond, who've been participating here at CU, and all the Denver Health trauma and research teams. So happy to answer any questions.
Thank you for that excellent talk. In the trauma bay, I'm used to seeing end-tidal CO2, as you mentioned, only as an indicator of successful intubation. Seeing that it correlates so well, do you have any preliminary guidelines to say, hey, this amount of it being lower than expected or higher than expected should trigger this action? Or is that the hope, is to eventually get there, to use it to guide, this person should go to the STICU, this person should get a unit of blood despite a normal blood pressure because of the end-tidal CO2 abnormality?
Yeah, I think if I understand your question, you're asking, is there a certain like kind of cutoff and how do we intervene based on those numbers? Is that what you're asking? Yeah, so the cutoffs based on all the studies we've done are in the kind of low to mid 20s. So a patient that is below that is at risk for massive transfusion or death. Now, I think how you intervene on that is going to be kind of multifaceted, right? So, patient that is showing maybe a low normal blood pressure, 100 systolic, that end-tidal CO2 is 20. I think that's someone in the right clinical scenario, you might want to jump on transfusing blood a little bit sooner, maybe not wait to see their blood pressure drop, because you're really showing that kind of extra sign. It's almost like, in my mind, patient that has a heart rate of 100 and a tachycardic of 140. Like that's worrisome, right? Even though their blood pressure is kind of low normal, like that's worrisome. And so the end-tidal CO2, I would also look at in that same vein. Of course, if you see a severely low numbers in the teens or single digits, you got to look, make sure your airway's in the right place and look at other things. But I think it's just one factor that you want to use. The ideal world, which I'd like to prove, is that in patients that are in that kind of low normal blood pressure range, that have that low end-tidal CO2 value in the field, that we can go ahead and activate that patient, get those resources at the bedside, because what we're seeing is these are the patients that kind of right on the precipice, especially the young, healthy patient. And I think it probably really applies as well to kids, even though we haven't actually studied that population, is that they'll hold on to that last moment to their blood pressure. And if you don't recognize that, they go over the cliff and you kind of miss the opportunity.
Really next time, I didn't feel out. Wait for the microphone for the online. Okay.
Hey, Eric, and really nice talk. What do you think needs to get better? There are a lot of good engineers and tech people in this audience for this to work in non-intubated patients better. With a better nasal cannula, do you have any insight about what we need to do to make the technology better so this works in the field, in austere military settings, whatever else?
Yeah, that's a great question. I think that's one of the things that we're trying to find out. So without giving away too much of the upcoming study that'll be kind of embargoed, there's definitely still a signal using the end-tidal CO2 nasal cannulas. What we can't tell in the current studies is, did the nasal cannula fall off at any point? Did we get data that whole time? Is it put in the right place? And so I think the next steps from a study standpoint is really to get enough funding so that we can do this in a true observational fashion, where someone's actually like recording, maybe not in the pre-hospital setting, but at least immediately debriefing the medics as to like, did the nasal cannula fall off? Did you have it in their nose the whole time, et cetera? Because that's the part that's a real limiting factor for us. I think once we have that data that we can trust is accurate throughout the study, then it's really going to come down to computational mathematical modeling, because I think improving that will allow us the ability both to combine their end-tidal CO2 data with their other physiologic things, their heart rate, their blood pressure, et cetera, to get an even more accurate model. So I think that's the future.
So Eric, are you looking at absolute levels or discrepancy between end-tidal and blood gas? And that's part A. And part B is really the absolute value or the difference, the right measurement or the change over time. If it's trending one direction, i.e. getting more equivalent, that seems like a patient who's getting better. Whereas they're trending and diverging, that's a patient who's getting sicker.
Yeah, that's a great question and comment. So in the first study, we in the operating room, we had ABGs to compare to, but of course in the pre-hospital setting, obtaining ABGs is not very practical in the ground ambulance setting. It can be done in the helicopters. And I hope over time they'll be able to do more of these point of care testing in the ambulance. And I would love to compare the two, because I think that would be even a much stronger predictor. But what we're finding already is that just the absolute value is predictive of shock and death. And that what I really like to see, and that's going to come with future studies, to the ability to trend this over time. So let's say if you have a long transport, for instance, here in Denver, we're lucky to have very short transport times, but in other places around the country, 20, 30 minutes or more, it would be really interesting to see, okay, the end-tidal CO2 is trending down. Let's either give some fluid, give some blood if we have that available, or make another intervention and see that start to trend back up. And I think that would be really informative to our medics. And again, with minimal cost, this is equipment they already have on the ambulance as it is.
Is one of the variables of end-tidal CO2 your ventilation rate? The higher the ventilation rate, the lower your end-tidal will be because you're moving it out of the lungs faster. So how do you normalize for that?
Yeah, so essentially what you're looking at is if in patients that are in shock, you start to get a disparate value in which your end-tidal CO2 is actually not really predictive of your plasma CO2 at all. And so even if you're hyperventilating, it's not necessarily going to affect it in the same way because your lungs are not well perfused. And so there is a point, and this is one of the issues with the first study, that if you get into such severe shock, it doesn't matter what you do to your ventilation at all, that end-tidal CO2 is going to remain low. And because you just simply cannot exchange the CO2 across that barrier.
But how do you differentiate between the shock
Yeah.
versus you with the the ventilatory rate 4 more breaths per minute?
Yeah, so in the population, what this is predictive kind of regardless in my mind. So like if the patient is in severe shock and trying to compensate, they blow their own CO2 down, that's a marker of injury already. If they can't blow their own CO2 down because of this problem, you're still showing a severe marker of injury. Where this may become an issue is if you're trying to intervene and you don't see it rise, well, it may be because it just can't. Does that make sense?
For questions or comments? All right. Thank you, Dr. Campion. Happy Halloween. Have a great day, everyone. Thank you.